We shall now go on to our next speaker, Dr. Elizabeth Joseph, who is the Chief of Pediatric Ophthalmology and Strabismus Services from Flower Hospital, Angamali, and a very well-known, popular person in the field of ophthalmology, just not pediatric ophthalmology. So,
thank you very much, Dr. Chitra, for including me in this presentation in this webinar. This webinar involves a galaxy of excellent strabismologists India has, and I'm again thankful for being here. My talk is on taming the superior oblique. See, superior oblique surgery is one of the most challenging of all the strabismus surgeries, and this will require a thorough knowledge of the anatomy, and strabismologists have to be having extensive experience. And the preoperative decision making is also very important. The common indications for superior oblique surgeries are Brown syndrome, A-pattern superior oblique overaction, superior oblique palsy, and the common procedures are superior oblique chicken suture, silicone band expansion technique, Z-plasty, split tendon lengthening, all done for Browns. Superior oblique partial tenectomy, mainly reserved for A-pattern strabismus. And then there is the superior oblique tuck, Harada-Ito procedure, superior oblique advancement, etc., done for superior oblique palsies. When we are doing a congenital Brown, in the mild and moderate cases, I would say that we better not do anything for the mild and moderate types of Browns, because the chance of down gaze diplopia and the superior oblique palsy is very high. Absolute indication for surgery is a severe case with a lot of head tilting and primary position hypertropia. And in my hands, the best procedure for superior oblique in Brown syndrome is superior oblique chicken suture or a tendon spacer. Both these procedures are controlled surgeries compared to other surgeries. The tenectomy is nowadays not done. The highest success rate, I think, is with these two procedures or with a split tendon lengthening. And here, iatrogenic superior oblique palsy is very rare. I will show a small video clipping of this that is gone superior oblique palsy. Video is not playing. Yeah, before doing a superior oblique chicken suture, we have to do a force reduction test. Make sure that your diagnosis is correct. There is a restriction of elevation in the adducted position. Only then you take it up for surgery. And here you can see that the superior rectus is exposed, superior oblique is in my muscle hooks, and you can see a non-absorbable suture being passed on one end of the superior oblique. And after that, you make a loop of this suture material 8 to 12 millimeters, and then you pass the same suture 5 millimeters apart from the first suture, involving the entire width of the superior oblique. And you can see that the loop is made, and now we will pass a suture through the other 5 millimeters apart from the superior oblique. And then we are planning to cut the superior oblique muscle in between these two sutures. These two sutures will prevent a consecutive superior oblique palsy, and the suture will act as a scaffold for scar that can keep the cut end of the tendon away. After doing that, a force reduction test has to be done. Now you can see that sutures are placed, and now the tenotomy is completed. After doing the tenotomy completely, you do a force reduction test again and make sure that the force reduction is negative. And then most probably the surgery will be successful. See, this is one postoperative picture. You can see that this is a left Brown syndrome with absence of elevation. After the surgery, on the first postoperative day, elevation has improved. And this is another person who has got a right Browns, underwent the surgery. This is the post-op picture. 1.5 years later, you can see the cosmetic improvement, very remarkable. So this can result in a good result. Now coming to the other commonly done procedure, superior oblique tuck, which is done for underaction. And tuck will be done in superior oblique palsy, where there is a laxity of the tendon. I think I don't have to show the tuck in detail, because Dr. Meenakshi has already shown the tuck, but 1 or 2 points. before doing the tuck, you mark the 12 o'clock, 6 o'clock and 12 o'clock meridians on the limbus, and after the tuck, make sure that it has become slightly intorted. The extorsion has to become a little bit of intorsion, and after the tuck, always do a post-duction test and make sure that you have not created an iatrogenic browns. So this is how we do the tuck. A non-absorbable suture is used. And if you want to do an 8 millimeter tuck, a 4 millimeter measurement is taken, and a non-absorbable suture is used just like this. A post-duction test has to be done after that. And you can see the pre-op picture. You can see the child has got a head tilt with primary position hyper, and after the surgery, you can see that the primary position hyper is corrected, and the head tilt is corrected. Here I have done an inferior oblique recession along with the superior oblique tuck. Harada-Ito procedure, I would like to show the video because it was not shown early. Here in Harada-Ito procedure, the principle is that the anterior fibers of the superior oblique are the torsional fibers. So in case of congenital superior oblique palsy where torsion is a predominant factor, you do surgery involving only the anterior fibers. Here you can see that the superior oblique muscle is split into the anterior fibers and posterior fibers, and then the anterior fibers are isolated like this as far posterior as possible, and then a suture is placed there, and the anterior fibers of the superior oblique is brought towards the lateral rectus muscle. If there is only a preoperative torsion of about 10 degrees, this surgery will work well. If there is more than 10 degrees, probably it's a bilateral superior oblique palsy where you have to do the other eye also, or in case if there is more torsion, you have to tackle the superior rectus. In addition to the superior oblique anterior, in addition to the Harada-Ito, you can do an anterior superior oblique tuck also in similar conditions, anterior superior oblique tuck. And coming to posterior tenectomy, this surgery is done to correct the superior oblique overaction associated with A-pattern strabismus, and there is no risk of superior oblique palsy here. Here the posterior fibers of the superior oblique is cut. You can see the video of posterior tenectomy. Here only the posterior, this is the exposure. You expose the superior rectus first, and then you go to the superior oblique.
And we have 1 minute remaining.
1 minute more. Yeah, you can see the superior oblique, the entire superior oblique in my muscle hook, and you cut the posterior fibers alone. That is the posterior tenectomy of the superior oblique. You can see we are cutting the quadrilateral piece of the posterior fibers. And now I conclude this talk by giving you my take in superior oblique surgery. One thing is that when you do superior oblique, be careful that there is a risk of inducing new vertical and torsional deviation. So you reserve your superior oblique surgery only to the deserving patients. If there is in bifoveal fixators, whether the patient has got good fusion, be careful. And during superior oblique surgery, an intraoperative FDT should be done to prevent an iatrogenic browns. And intraoperative monitoring of torsion is also important. And a good clinical outcomes occurs in appropriate clinical indications and in selected cases. The choice of the surgical method should be individualized to avoid complications. With that, I'm stopping my talk. I think I kept the time. Thank you very much.
Thank you, and a wonderful talk also. So crisp and so definite.